I'm Dan Collins with Mercy Medical Center in Baltimore, Maryland, and you're watching Medoscopy. Thanks for joining us for today's procedure. Our guests today are Dr. Neil B. Friedman, who is director of the Hoffberger Breast Center, and Dr. Maria Jacobs, who heads radiation oncology here at Mercy, who will be joining us in our program's second half. Dr. Friedman, before we went live here, as it were, you mentioned you had a funny story to tell, so I want to jump right in. Tell me this story.
Hi, Dan. So you were just pointing out the accoutrements here that you have and pointing at the people like the purple skull. So that reminded me of a funny story. So when I was in medical school, which was many years ago, we had a bone box to learn anatomy. And they were real skeletons of people who donated their body. And you got to take them home so you could look at your books at night and look at the bones and figure out, what the bones were, where the muscles inserted and all that sort of stuff. So we had a skull, and we started school obviously in August, and Halloween came along not too long later. And so we put the skull on our windowsill in the house. We thought that was quite amusing. Obviously, people saw the skull and didn't know that it was real. So that's what that reminded me of.
Well, I have no problem with that. Both my wife and I are donating our bodies to science for when we pass away. So like I say, for we people in PR, we never stop working. So even when I'm dead, I'll still be working, helping to continue the efforts here. So that's fine by me. That's a cute story.
Well, that's very nice. I mean, I guess they still have, bodies for anatomy.
Yeah, the Maryland State Anatomy Board.
Yeah.
So,
I mean, a lot more is virtual than it used to be, but, how else do you learn except by really looking at things?
Exactly. One of the questions I usually like to ask is how the physicians I'm speaking to got into medicine in the first place. Was this something you always had an interest in, or, this was like, wow, I didn't think I was going to wind up in medicine?
So I'm surprised you know that as the PR person, you haven't read some of my blurb in something somewhere. So there's a story, a TV show called Medical Center with a surgeon, Gannon.
Yes.
Many, many years ago, and I saw that as a kid and said, oh, that's really neat. That's what I want to do. And I was 16 years old, but that's what it was, and that's always what I wanted to do, and just things turned out the way they did.
Oh, that's awesome. I understand that you've had some other interests. One of those includes construction. Can you tell me a little bit about that?
I've always been fascinated by that. Loved construction, thought it was really sort of neat. Not so much houses, which are nice, but big projects, hospitals, shopping centers, big office buildings. In fact, when they were building this building, we're in the Weinberg Center at Mercy. My previous office was across the street, and I could look out the window and watch this construction being done, which I did. If my staff couldn't find me, they'd go around the corner and they'd see me looking what was going on. And in fact, at that point in time, one of the people's wives ended up getting a breast cancer, came to see me, and he goes, well, do you want to go in that building? So sure enough, they gave me a hard hat. And when this building was being constructed, I came in here, went up ladders. When Tom Mullen, the CEO, found out I was in here on ladders, he almost had a stroke and said, you're not going in there anymore. But just to watch what they're doing and all the intricacies of what was going on, I found fascinating.
Is there a parallel there? In other words, as a surgeon, you're working on the human body. You see how all the different parts work together when they're not working together. Similarly, as you're constructing a building, all the different pieces that have to go together for the final outcome to be what you want. Do you think that works?
Yeah, I do think it works. I think it sort of makes sense. What I always tell, my kids is, if you make a mistake on a piece of wood, you can throw it out and start again. I said, I can't really do that. It doesn't work terribly well. But yeah, I do think there's some similarities there, but I've always been fascinated by construction.
Now, how long have you been in medicine now? How many years?
If you count from medical school, 43. I've been a physician, a surgeon for over 30 years.
Wow. And
long time.
When did you come to Mercy?
I came here in December of 1996, beginning of 1997. So we're almost at 25 years.
So December of 96, I came in November of 96, so we almost came on at the exact same time. So yeah, it's been a long road, you and I together.
Yeah, well, I mean, I remember, when back then when we did the spots on WBAL, and there weren't nearly as many physicians. So I was on several times my first year because you needed us to go multiple times because not as many people to choose from.
Well, we talk about funny stories. That reminds me of a piece that we did with you with WBAL. And again, this is a long, long time ago before this building existed, so at least like 20 years ago, where they had to do the obligatory hallway shot with you. This is where they shoot the physician walking down the hallway. The problem was you were so driven and intent, you were walking so fast, they kept saying, "You're going too fast, doctor, we have to do it again." And you're like, Dr. Friedman can't walk slow. He's never walking slow. He's always direct onto his next thing. So that always kind of stuck in my mind after all these years. And you're always on the go, wouldn't you say?
Yes, yeah, and today is one of those days. Yeah, no, I mean, I've slowed down just a touch, but not that much.
Now, over a 30-year period, you've probably seen a lot of major changes in your field. What do you think is one of the most significant?
I would probably say the chemotherapy, and it's not just chemotherapy these days. It's chemotherapy, it's immunotherapy, it's hormonal manipulation. I mean, I just had a conversation with a patient this morning whose sister has metastatic breast cancer. And back when I started, if you had that, almost everybody died within a couple of years. Maybe a few lived 3 or 4 years. Now they routinely live 5, 6 years, and some of them much longer than that, with a very good quality of life during that time. Let alone we're giving much more chemotherapy and other related drugs preoperatively now and shrinking tumors. So I would say that the chemotherapy related, the drug related changes has just exploded over the past number of years, all for the betterment of the patients.
Do you think we'll ever see a cure for breast cancer?
Those of us who do this for a living don't like that term because there's plenty of people who are cured, who get diagnosed at 60 and they have their surgery and whatever it is, and die at 88 from a heart attack or a stroke or whatever. So they were cured. You're always reluctant to say that to people because occasionally I had a patient recently who over 30 years later recurred, which is very unusual, but it happens. So do I think we cure a bunch of the people we see? I do. But you're reluctant to sort of say that because that implies that it will never come back. And sometimes it's hard to say that to people. But I think that the stage that people are getting diagnosed earlier and earlier, our treatments are getting better and better, and people are living longer and better during that time.
One stat I came across said that breast cancer death rates have declined 40% between 1989 and 2016 among women, and that this progress is attributed to improvements in early detection. Would you agree with that?
Partially, and I do think early detection has had a role in that. But as I just said a minute or so ago, I think the other huge role, probably more than early detection, is the chemotherapy, hormonal therapies, immunotherapies. There's no way that you can separate those things out, but I think if I had to make an educated guess, those therapies have probably had more of an impact than just early detection.
What do you think, this idea that we might eventually be able to, tailor the therapy to a specific individual, is that possible?
I mean, I think we're already there. I mean, I think that's what you call personalized medicine. And I think people don't realize that probably one of the first personalized medicine approaches was tamoxifen. So breast cancers, you look at these things called receptors. They're the estrogen receptor, the progesterone receptor, and the HER2 receptor. That's what we look at now. And those are individual characteristics of individual, not patients, but tumors. And you tailor the therapy to those receptors. So somebody who's hormone receptor positive, ER/PR positive, you can give tamoxifen to. Well, that's personalized medicine. And we've been doing that for well over 30 years. But for a long, long time, that was it. There was nothing else that you could do to personalize it. Then came the HER2 receptor, where we use Herceptin. That was the next big personalized step. And that was probably, 8 years or so ago. But now there are more and more receptors that we're looking at. Again, receptors for immunotherapy, other sort of receptors, other personalized or individual tumor characteristics where we pick therapy based on those characteristics. And that's what's changed the treatment of breast cancer patients dramatically.
I was wondering, most of the physicians I talked to mentioned that there was a particular mentor, somebody in their lives that made a significant difference to them in terms of their understanding and practice of medicine.
Back when I was in medical school, I was making rounds in my surgical, rotation, and this patient had an amputation, and the person who was the senior person on the group of us making rounds sort of ripped off the bandage sort of roughly, and the patient was very uncomfortable and winced. And I just thought to myself, gee, if you had just taken another couple of minutes and taken it off more slowly, it'd have been a much better experience for the patient. That's a learning. You can learn from negatives as well as positives. So I don't think there's one particular person, but there's different pieces I've taken from different things in life, experiences that make me, who I am.
I want to talk a little bit about causes of breast cancer. There's a lot of studies right now going on that look at the effects of physical activity, obesity, weight gain, diet, and these are, of course, major issues in the United States in terms of impacting breast cancer risk. What's your thought on that in terms of breast cancer causes, what people need to know about in terms of what they can control, but then there are things that they can't control?
So I'm going to start with what you can't control, which is your inheritance, your genetics. Family history is the most important factor in breast cancer. Specifically, I'm looking at genetic breast cancers. Mother, sisters, it can even be your paternal, your father's mother. Sometimes people forget that, but you inherit genes from both sides of the family. And if you have one of the breast cancer genes, the two most common are BRCA1 and BRCA2, although there are others, your risk for developing breast cancer is very high. You can't control that. There are some things that we can do. Certainly we can follow you more closely. So if you have a family history, you need to talk to your physician to see if you or one of your relatives needs to get genetic testing. However, of all the breast cancers, only about 10% are based on your genetics, maybe 15%. The vast majority are what we call sporadic breast cancers, which means they're breast cancers that arose for reasons that we don't really understand. So one of the things that you can control, you can control your weight, you can, at least to some degree, you can control your diet, you can control exercise. So when I tell my patients all the time about breast cancer, you should try and lose a few pounds, like all of us. You should try and eat more chicken, more fish in particular, more vegetables, less red meat, drink a little bit less. But do those impact the breast cancer risk? They probably do, but probably to a fairly small degree. But those are the only things that you really can control. And even if they don't affect your breast cancer risk terribly much, they're certainly going to affect your overall health risk. So that's what I recommend to patients. But there is no magic bullet that you can do, except just make sure you get your mammograms and make sure you keep a healthy, persona in general.
So I get the sense that you're someone who doesn't have a whole lot of free time. You're usually pretty busy, but you must have some time when you aren't doing you're not doing the doctor thing, you're not in surgery. What are you doing when you're not in surgery?
So probably, I like to read. The other thing is we fortunate enough they bought a place at the beach several years ago. So particularly in the summers, I'll go down there a lot. I have 4 children, and I've been fortunate that in the past several years, I've had 5 grandchildren in the space of 2 years, who I love to see. A number of them are close, but some aren't, so we have to travel. So we see them as often as we can.
You mentioned you like to read. Any particular authors spring to mind?
Mostly sort of bang, bang, shoot 'em ups. This is a completely apolitical statement, but Bill Clinton wrote a novel recently with James Patterson. I read the second one first, which was I think the President's Daughter's Missing, or The President's Daughter, and I thought it was a great book. But it's mostly sort of mysteries and those sorts of things that I like.
Our next guest is going to be Dr. Jacobs in radiation oncology. She does some work with something called IORT that I know you're also involved with. Can you tell me a little bit about that?
So IORT is intraoperative radiation therapy. We've been doing it here for a little over a decade. Started mostly actually in England and somewhat here, but mostly in England. And if you do breast conservation, a lumpectomy for a cancer, rather than a mastectomy where you remove the breast, you have to have radiation. And for years and years and years, we radiated the entire breast. And then people were thinking, well, gee, can you just radiate the area around the tumor? And it wasn't so easy to do technically, but one technique that developed is using a type of balloon catheter. It's actually firm, that you put in the breast and you deliver radiation to the cavity around where the tumor was. So a study was done a number of years ago, published in The Lancet, which is a British medical journal, and very promising results. So about a decade ago, we went and learned the technique and started doing it here. We've done about 250 patients, and we have a less than 2% risk of recurrence in a decade, which is very, very good numbers, and great survival rate, very low risk of local recurrence. Cosmetic results are better than whole breast irradiation. So we've been very, very pleased with that.
Dr. Friedman, thanks for joining us today. We'll be back in our second half of our program with our interview with Dr. Maria Jacobs.